Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
The world is becoming smaller in the COVID era. The spread of knowledge and information is more fluid than ever. We are so grateful for all of the men and women working hard throughout the world to share their experience so that we may as a society stand united against this pandemic. From among the nations most heavily affected, we have benefited from the webinars and articles from China and the news stories and podcasts from Italy. But we cardio nerds knew there was valuable information to be learned from our colleagues in Iran. Iran is the sixth most affected country with over 21,000 COVID-19 cases today and over 1,600 deaths.
With this episode, the Cardio Nerds podcast is proud to bring you a unique perspective from the heart of Iran. From a critical care doctor at a large academic hospital in the capital city of Tehran, we share with you the Iranian experience with COVID-19, a first-hand report from Dr. Reza Hashemian, covering the clinical, the societal, and the personal. Among the topics we discuss is the use of non-invasive positive pressure ventilation versus intubation strategies on patients with COVID. Please tune in to episode 19, COVID in the ICU, with Drs. Farfaro and Drs. Brusca for a nuanced discussion on the topic.
This episode was recorded on March 21st, 2020. Remember that knowledge in the COVID-19 era is rapidly evolving, so it's important to stay up to date with professional organizations like the WHO and the CDC, as well as your government officials. Friends, also remember, this podcast is not meant to be used for medical advice. The views expressed here do not necessarily reflect the opinions or policies of our employers. The goal is simply to enjoy learning more about cardiology in the COVID era directly from expert cardio nerds.
And this is really just such a special episode, and it makes our hearts flutter to help connect people from different parts of the world. This particular episode is made possible by some key individuals. We would like to thank these friends for helping us frame our interview within the context of the beautiful Persian culture. Dr. Seper Rajai, pain specialist, and Dr. Roya Mahmoudi, pediatric dentist, both in California. Dr. Sama Nimatolahi, infectious disease fellow at the Johns Hopkins Hospital. Dr. Reza Zanozi, nephrology attending at MGH, and of course, Dr. Reza Manesh and Dr. Arsalan Darakhshan from the Clinical Problem Solvers team. And a very special thanks to Dr. Farhad Safari, anesthesiologist in Tehran, for introducing us to our expert star guest for this episode, Dr. Reza Hashemian. Welcome back, Cardio Nerds. We are here with Dr. Hashemian from Tehran, Iran. We're very excited to learn from his experience. Before we get started, Dr. Reza Hashemian, we would like to say on behalf of us Cardio Nerds, your friends and colleagues, your fellow healthcare brothers and sisters, Ade Shoma Mubarak, Happy Persian New Year, which just passed on March 20th, 2020.
We wish we were celebrating with you under different circumstances, but here, amid the COVID-19 era, we can only imagine how busy you must be working so hard to serve your patients in the busy ICU in Iran, one of the hardest hit nations of the COVID-19 pandemic. So really, thank you so much for giving us your time, and we really, really appreciate it. It means so much to us.
Thank you. Thank you, sir. Appreciate for giving us about the message for the celebrating of our Nowruz. And I am Dr. Hashemian. I'm an intensivist, critical care medicine fellowship. I have a fellowship from my country, and I am fellowship of ACCM from the Society of Critical Care Medicine in the United States too.
Oh, wow.
Yeah, I know everything about everything you are doing in the ICU or in your hospitals. Nowadays, I spoke with lots of my friends in the United States, and we are doing something like United States, something like Chinese about COVID-19, and many things based on our hospitals and our customs.
Thank you. Can you tell us what city and hospital you're practicing in now, and what's the data affecting patients in your area?
Okay. I'm doing my job in the biggest referral center of lung and heart transplant in my country. The name is Masih Daneshvari Hospital. This is a WHO-based hospital for tuberculosis and lung disease. This is the referral center for COVID-19 nowadays, because in the first day of visiting a patient here in COVID-19, when we get kits for COVID-19, we change this hospital to a referral COVID center in Iran. And nowadays, this is the famous hospital in Iran that we are doing here treatments for COVID-19 in Iran.
Dr. Hashemian, I'd like to ask you a little bit about the public health response, especially with regards to social distancing in the community. And I'll preface this by letting our listeners know that Nowruz is the Persian New Year. We just passed this Friday on March 20th of 2020. And there are some traditions that I've learned from my friends that are very much a part of the celebration. One tradition is traveling to northern Iran to celebrate the Caspian Sea. And the other is a tradition called, and I hope I'm pronouncing this right, Did o Bajdid, which is the tradition of visiting and revisiting relatives, and a tradition where young people will visit their elders and invite them back to their homes. So Dr. Hashemian, correct me if I said any of this wrong, but also how has COVID-19 affected these activities, and are people making the decision to stay home, or are they still celebrating outside as before?
Thank you for speaking in Persian languages, Shema Mubarak, or other things. The Nowruz is an ancient table of our peoples in Iran, and this is a very good traditional because we like this. We are waiting all of the times for the Nowruz. In the Nowruz is in the spring. All of the people like to visit other families, friends in this time. And nowadays they are very unhappy. Nowadays we have a problem, about the COVID-19, and we are very unhappy to see this COVID-19 nowadays in the Nowruz time. And lots of people are remaining at their home due to the TV announcements and the government announcement, and lots of people, maybe at least 30% or 40%, are in the traveling to the other cities or to the north of Iran, the Caspian Sea. Unfortunately, because the quarantine is not mandatory here in Iran, and the government didn't push all of the people in their houses, and this is not very good points for us, because we are waiting for the next widespread infection problem in our country, unfortunately. Then this is a big disaster we are thinking about the next weeks. Our ICU beds are efficient nowadays for our peoples here, but we don't know about the next weeks for the second period of widespread infection here. Then people that remain in their houses, they are for example, in the Instagram and asking other people, please don't going outside of your house. They are frightened from extending the time of this disease, and the house and physicians and nurses, they are frightened from extending this period too. Then we have good people to remain at their home, and unfortunately, other peoples are in the markets or in the trips nowadays.
It must be impacting routine Persian life, like you said, people going to the markets and being able to buy other essentials.
Yes, the big market nowadays is closed here in Iran due to Nowruz and due to this big problem. But for example, lots of people like to going to other homes or other, for example, the small market. Then the traveling is remaining nowadays in Iran, unfortunately.
I see.
Is it?
We have the traffic jam. We had the traffic jams 2 days ago in many roads, unfortunately, in Iran again.
Oh boy.
We have traffic jams. Yes.
And Dr. Hashemian, I'd like to turn our discussion to a very, I think, key issue. While international policy and economic sanctions are outside the scope of this podcast, we want to ask you if the sanctions imposed on Iran are affecting your country's ability to respond to this crisis and your ability, frankly, to just take care of your patients. And if so, how are they impacting these issues?
Yes. We have two type problems in Iran. One is COVID-19, and another is the sanctions. As U.S. government told that we have not any sanctions for food and for drugs for Iran. Unfortunately, we have not any money transaction between Iran and other countries. Whenever you have not any chance for sending the money or getting the money from other sides of the world, then the sanction will be remain here for the food and for the equipments, medical equipments, and for the pharmaceuticals. Then this is a big problem. Now, lots of countries, they like to helping us, to sending us the pharmaceuticals, and we are speaking with those people or that governments with our ministry and asking them to sending us the pharmaceuticals.
Mm.
So we've been hearing a lot of reports all over the world, and as the COVID virus even gets closer to home, of a lot of healthcare workers getting infected. And we were just wondering, what has your experience been in Iran? Have you had any close friends or other healthcare workers that you work with or colleagues become affected by the virus?
Oh, about healthcare workers, we have a big problem here with the healthcare workers nowadays. The one is related to the kids, because the first presentation of the COVID-19 it was in home in a city near to Tehran. The first presentation, it was with the mortality and the big mortalities. And after checking with the new kids they bring from the China, they understand that this is the COVID-19. And we noticed the COVID-19 when we getting the kit and checking this, one of our patients that he referred here for management of the ARDS here. And we thought that maybe this patient is undergoing H1N1. And when we checking the new kit, we understand that this patient is undergoing the COVID-19. And this was a big problem. Why? Because lots of healthcare workers was affected with this COVID-19, and because we didn't thinking about the COVID-19 in our country, and the exposure of these teams was very huge, and we had at least 15 physicians that they died.
Oh my gosh!
Oh, I'm so sorry.
God, yeah.
Wait, you said
physicians that they died here, and at least 10 nurses that they died from this.
I'm so sorry.
They are working for their duties for the people, and this is a very, very bad news for our people and for us. And I tell you about another things. Lots of those are affected nowadays, and they are in their home and they are in quarantines, and we have lots of nurses affected nowadays with the COVID-19, and we lost lots of them, and they are not in their duty nowadays. And I don't know about the future, because maybe if the epidemic is larger, more larger than now, we may be lost amount of healthcare workers nowadays. Thinking about the future, I tell you something. For example, we missed 3 physicians in our hospitals, and that day, all of my staffs was crying in the ICU, and it is not very suitable things, and it's a very big disaster, unfortunately.
So sorry to hear that, Dr. Hashemian. This is very sobering. Dr. Hashemian, you said that one of the biggest issues in the beginning was the first few patients that came in that exposed healthcare workers. You did not know that they were infected because you did not know about COVID.
Yes.
Now that you know about COVID, is it easier to protect your colleagues and other healthcare workers?
I'm asking you about which type of protection. You mean the clothes you see, or about the test?
Both. Okay. This is not routine things for checking the healthcare workers, but whenever each physician or nurses likes to knowing about them, they will be checked. Nowadays, we have more kits from all of the sites around the world, and we have, I hear that Iran nowadays have a technology to producing the kits, but I didn't check it. And they sent lots, the companies bring it the kids for us. For example, I check myself 3 times, and lots of my friends check themselves. But it's not routine to checking that healthcare workers checking themselves routinely. And about the protection, this hospital is based on their routine standards. The protection is very magnificent here. If you're checking our clothes in our hospitals, you notice that we are a standard. And when WHO came here to see the levels of care here, they understand that we have good clothes and good wearing and good protections here. We have not any problem. But I know that in the first days, in all of our countries, the physicians, nursing, they have not very good protected against the COVID-19. And we're asking other hospitals or cities that please providing the good protection for yourselves. And I think the big problem for that physicians and nursing at the first time that it was that the kit's not available here, and the second one is that the protection was not efficient for them.
How are you protecting trainees like fellows and residents and students?
We have good clothes. We spoke about lots of companies to bringing us the protections, and all of the fellows, all of the residents here, they are protected. I tell you something. In the first days of starting our work here in the COVID center here, Chancellor of the university came here and told us the medical students, they have to remain at their home, and because we are working in a university hospital, and we have not any medical students nowadays in our hospital. Then we have residents and fellows here, and they protected very good. They have efficient masks, they have good protections, but it's related to our hospitals. Maybe in other hospitals they have problems.
Right.
But I know that they are better than before because they saw our clothes and asking us to reveal for them about the details and asking the companies to bring those from the government. And government really sending the clothes very nice for those. And lots of charities in Iran available nowadays.
That's incredible.
And the people are sending the clothes and the masks and other things for us.
Dr. Hashemian, it's a difficult time, but seeing how people and communities come together at a time like this is at least a silver lining. And we applaud your efforts to protect your learners. How do you limit the spread of infection from one patient to another patient that are in the hospital?
In our ICUs, we have negative pressures. And negative pressure, is very efficient for us because we had an influenza center here or tuberculosis center, and we had negative pressure in our ICU. And the negative pressure is very standard for this type of infections spreading. And about the wards, because the wards are separated with the walls, and for example, 2 or 3 or 1 patients are in the room separately. We don't doing more. And I don't know about the details of separating better than this. Maybe it's available. I don't know. But we have not any options here.
Yes.
If there is separate rooms for each patient, it's very good. But we have not this type of rooms here. For example, we have only 10% one rooms, maybe 30% one rooms for 2 patients. And this is a big problem we have in Iran for the separations of the patients. But we, at this moment, when we checking the PCR of the patients and when they are negative, they're sending these patients to the COVID negative site. And then after this examination, we send the patients to their home.
I see.
I'm so sorry again that your colleagues have passed away from COVID. How are you preparing emotionally and personally to face each day and go to work?
And this is very horrible for us. I tell you, fortunately, we didn't miss the physicians in my hospital. This is a referral center and a well-known center, and lots of physicians came here for the treatment and treatment. They are not from our sites. Now, 2 physicians of our hospital are infected, and they are treated very good, fortunately. But when we lost the physicians, we are very unhappy, and it's not very good moments for us. But in the verses of that moments, we have lots of physicians and nursing that they came here and they were treated. They had many of those have big ARDS, for example, and
Yes.
two of those physicians are very famous physicians, and we are happy to treat those physicians, and they came back to their host, fortunately.
Wow, that's great.
And I tell you, for example, 2 or 3 of those were couple, and they are treated together in our hospital. It was very fantastic for us to send them to their home.
Oh, that's incredible.
Mm-hmm.
That's really nice.
Mm-hmm.
This must be putting a lot of extra work on your hospital and the workers in your hospital. How are you dealing with the extra patients and the amount of work that COVID is creating?
Nowadays, in the first days or weeks, we have problem with the high load of the people. And now it is better than before because lots of hospitals, university hospitals, military hospitals, and other facilities, they are working for the COVID-19 nowadays. The private hospitals in Iran, they are not included for the COVID-19 in maybe more than 90% of those hospitals are not working for the COVID-19. Fortunately, at this moment, then the occupied beds are from the university and military or governmental hospitals. And I think based on the critical care medicine journal publication in last month, the ICU beds in Iran, these are better than the China, These are better than the China. And we have not any problem nowadays about the beds. But I told you about maybe after the Nowruz, we have the big problem for reducing the beds. And now in the bigger hospitals, the government producing lots of beds, and in the stadiums, they send lots of beds. If the epidemic is more widespread in that moment, maybe, and the occupied bed is going to be a big problem, then that empty beds will be in the circle. And I pray for that. I think in that moment is not very good because the healthcare worker is not efficient for that big beds in Iran.
Right.
We and at this moment we have not any problem for the beds, but maybe we have problems in the future.
I think we in America are facing a similar future, and I think we're all praying together to not make that realization. How has life changed outside of work for you and your family?
Oh, it's very big problem for me because every day I am, for example, every time I'm going to the home, I am thinking about my wife and my son and girl, and I don't know what am I doing because I'm changing my clothes and then going to the bathroom in my home. Lots of time I'm asking from my wife, please travel, because she's American and American and Iranian, and I ask her, please traveling to your home in the United States, and now she telling me the United States are affected. Don't worry about me. And,
None of us are safe, I think.
Yeah. And all of the globe are infected, unfortunately. But this is my biggest problem, because I am working in a very infected sites, and when I'm going to the home, it's very unpleasant for me. Then I'm so unhappy. I separated my room in the house. I separated all of things in my home. I didn't eating no things in my home by my family, and they are very far from me nowadays. You know this. I didn't touch my son and girl. I didn't going with those anywhere, and they are in the house. Then this picture is not very good. My girl likes to speaking with me, but I asked her, please be far from here. And she told me, are you encountered with the corona? And I told him no, but maybe you will be in the problem, my girl. Then this is a big disaster in the house too for the healthcare workers, unfortunately.
Yes, I have to reflect on what you're saying because my co-fellows, and I know Dan's co-fellows and Heather's co-residents, we're all having the same conversation about what we do when we come home. What do I do when, I come home to my wife and my 2-year-old son? And, whether we're in America or Italy, Iran, China, anywhere really, it's just your comments make me realize that the basic essence of human condition, emotions, love for one another are really all the same.
Yes, I like to remain, for example, in the hospital, not going to the home, because my daily problem is when I am in the home, I have to remain in my room and don't touching my family. This is my big problem that I hear, for example, my wife is in the COVID positive, and everything related to him is from me, because she is in the home, and if she encountered with the COVID, then the problem maybe started from my contamination. This is correct or not?
Yeah, I understand. I was supposed to see my mother last week, and I similarly decided not to because I didn't want to put her at risk.
Mm-hmm. Yes, and other things. For example, more than 10 days that I didn't go to my mother's home, and when I like to see him, then I call him with this WhatsApp and see him in the phone, because she's in the aging time, and I don't like to affect her with my contamination. You know this? Maybe I have a problem sending the virus to her, and in aging time, this is a big disaster for my mom too.
Yes.
Yeah. This is really special for us. We've heard a lot about what's happening in China, and we talked to some Italian physicians as well, but we really appreciate hearing about your experience in Iran specifically. And overall, what has your clinical experience been dealing with COVID?
The clinical presentations, they are coming to the hospital from the emergency room, fever, myalgia, and cough. And these are very common in the clinics or in the emergency room. And the physicians are visiting them and sending more than 80% of those to the home with the pharmaceuticals, for example, chloroquine and the previously oseltamivir. And now the oseltamivir is forbidden, and this is not prescribed nowadays. And the vitamins, for example, vitamin D many times, and naproxen as paracetamol at that moment. And if they have dyspnea, maybe because we have CT scan in our institute, then they followed by the CT scan. And then when they have problems in the CT scan and they have with the dyspnea, they admitted in the emergency ward and then going to the next level in the ward. And if they have mild ARDS, mild to moderate ARDS, and more problems with their breathing, they sent to the critical care units. And in the first day, I started non-invasive ventilation in our institute. And we have started in a non-invasive ventilation very good. And I asked the Philips company to bringing us more machines. And I saw in the WHO after 1 week that non-invasive is not very nice for the patients due to transmission of virus in the area. But actually, I'm doing that, the non-invasive ventilation before the intubation. And I know in the United States, you intubate the patient at the early time. And when I have experience from the H1N1, when we intubated the patient, the ventilator in this lung injury was higher than before, and the mortality rate was very bigger. At this moment, when I checking other institutes that they inserting the tubes for them, the mortality is bigger than that site, because in all of the hospitals they are practicing in Iran, they have not, for example, ECMO, and we are ECMO center in Iran too. We have 4 ECMO machines, and the machines are working every day. But the mortality in other centers are very high due to lack of the ECMO and good ventilators there. We have good machines, good ventilators, good non-invasive ventilation. In my practice that I started, and I like to publish my data about the non-invasive ventilation in these times, the using of non-invasive ventilation, we postponed the intubation, and lots of those now are free of ventilation, fortunately, and they didn't go into the invasive mechanical ventilation or the ECMO. Then the acute lung injury, or the ARDS that we are seeing every day. This is very unpleasant for us because all of the patients are coming to the ICU. The most patients are the ARDS. The next step maybe are due to motor organ failures, but the amount of the ARDS is more than other situations. Is it everything you like to know, or?
Oh, yeah. I have a follow-up question, but that was really a lot of excellent information. One thing is, so I know that the patients may be doing better from the non-invasive ventilation, but I've noticed that there's been concern about aerosolizing the virus when you're not intubated and making it more of a contagious thing for the healthcare workers. Have you noticed that, or is that also something that you haven't really seen in your experience with non-invasive ventilation?
And I have to thinking about the patient safety for the patients. I know that when we intubate the patient, we introducing for example, the secondary infection for those. We introducing the VAP for those, and the auto saturation of the intubation in many of those may be diminished. For example, when the saturation is 70%, after the intubation, it was diminished, and I know that lot of those was in CPR events, and they died after the intubation. You know this. I know that. All of the physicians knows because the intubation is not a very low risk situation.
Right.
You know,
right.
And it's better to increasing the saturation. And if the patients not tolerate the non-invasive ventilation, then you have a good time for the intubation of this type of patients. But the most problem that WHO speaking about that is the virus spreading. And I asking you about the virus infection in the invasive mechanical ventilation, because when the nursing are suctioning the patient, for example, or the intubating the patients, the virus may be widespread at that moment. Okay.
Great point. No, that's great. You mentioned that you're using ECMO in your center, and we were just wondering, are you using more VV ECMO or VA ECMO?
Okay. Nowadays, we have both ECMOs. We're doing VV ECMO and many times VA ECMO for our patients. The most problem in Iran we have is the sanction, because we have not big cannulas for the morbid obese, unfortunately, in Iranian because cannula size between the 29 and 31 French is available in for example, the Getting company, and the Getting company is not working here in Iran. And we have another company in Iran that they have only the 25 to 23 French size. And you know that this cannula is not providing more than 4 liters per minute vacuum. And if we insert in the negative pressure for those, it's remaining until 5 liters. And this is producing the hemolysis. And we had lots of hemolysis and increasing the bilirubin in at least 3 of those patients. Then this is the problem of the sanction for us, because this is producing the malpractice for us in this type of patients, you know. Okay, and we're doing both VV ECMO and VA ECMO for the patients. It depends on their situations. And we're doing hemoperfusion too. Chinese did hemoperfusion, and we have good hemoperfusion in our patients. And after hemoperfusion for at least 4 people, the saturation was increasing very nice. And maybe I report these patients and sending to a journal, because we have good experience with the hemoperfusion too. We did cytosort and another things working in China and Iran. Is the name is the company Jeffro, and we're doing the cytokine removal for our patient with the ECMO or with the CRRT. And about acute kidney injury, if you like, I was speaking about that. Or we're doing a CRRT and ECMO together and inserting the cytokine removal in the ECMO and in the CRRT at once.
It's great to hear your approach in these patients, because we'll be handling these ourselves very soon. We spoke a lot about the ARDS, but are you seeing injury of other organs like cardiac manifestations or renal manifestations?
Okay, about checking out the biomarkers, the cardiac biomarkers, these are not routine check, else the EKG or any patients that undergoing the hemodynamic states problem in the ICU look like the septic shock. We have to checking lots of things. For example, we checking the proBNP and troponin at this moment. But about the myocarditis, we didn't see our cardiologists in our ICUs. They didn't see the frankly myocarditis. We don't know why, because the Chinese statistics at least 7 to 9% is, and those are related to the rising the enzymes. But lots of the cardiologists from the other centers, they saw the non-ST elevations MI, and maybe they are due to the coincidental of their disease and the coronavirus. We don't know. Maybe the MI or ACS are producing that. For example, in our institute, the cardiologist didn't getting the MI or ACS previously because our ICU is referral for pulmonary hypertension and right heart. We are right heart center. About the echocardiography, we have good machines here, but when I asking about my friends and cardiac departments, maybe they see only cardiomegaly in the chest X-ray, and after that they checking the echocardiography, but it's not routine really for our decision to starting echocardiography for those. But the big question I have is many times we have good saturation in these patients and they're going to die for example, bradycardia. And this bradycardia may be due to chloroquine or maybe to Calitral. We don't know about that. And when we starting the Calitral, we didn't using the hydroxychloroquine, but we don't know about the exactly problem in their hearts. But another thing is about the acute kidney injury, about the kidney problem in Iran. Because I spoke with my friends in the New York City and the Cornell University, they have more ACI than us. We are very good machines for the CRRT here, and we're doing CRRT routinely in our patient. And the amount of CRRT in our center is not very higher than before. Unfortunately, we have not many ACI than before, but I know that in the United States, the ACI is more than before in the States. Is this due to the problem you have in using the mechanical ventilation more than us? Maybe because, when you are in the mechanical, the patient is on about the kidney problem. We have in the multi-organ failure, and for example, we have 2 ACI in the ECMO time. And at that moment, we have started a CRT for those patients. The multi-organ failure are related to comorbid disease or that situation. But if I thinking that COVID-19 is targeting the kidney, I don't believe in it. I think that the COVID likes to go to the pulmonary, not the kidney of the people. Then we are starting the CRT for multi-organ failure or in ECMO time or other these type of situations. It's not very strangely for us. And about the rhabdomyolysis. The rhabdomyolysis is not very high. It's very low. And the ARF was in the very lower stage. And when we checking the drug and changing the IV fluids for them, they goes to the recovery time. But we have three ECMOs that they suffered from the kidney injury.
Wow, thank you. Thank you for that.
And Dr. Hashemian, just real quick clarification because you cut out for just a moment. The rhabdomyolysis you were talking, was that in the context of a medication or in the context of the viral infection itself?
Maybe it's due to the disarrangement. I think disarrangement of the pharmaceuticals. I think it's a secondary problem, not the first problem of the patient, because the hyperkalemic was on that patients. And the kidney injury was starting. And one of those was related to the one CKD patients. And after dialysis, everything were changed.
I see. We're talking about many important resources, ICU beds, mechanical ventilation, ECMO machines, and perfusionists, nurses. Have you had a situation where you're running out of these resources and having to decide how to use them in which patients?
About equipments. We are better than before because in the first days of event of the COVID, we asking the MOH to bringing us the good machines for us. They accepting that, and the head of the hospital and the managers asking the charities to bring us more equipments. Then our ECMOs are better than before. The non-invasive ventilation are better than before. And we have the best ventilators, the Philips from the United States, 618, and we're increasing the amount of ventilators. And we have nowadays more ICU beds here because before we had 30 beds. Nowadays we have 60 beds, critical care, with all of the equipments inside it. And about healthcare workers, they are very good and very educated persons and very good persons, and for the working together. These are working against the corona very well. And I appreciate my staffs here in the ICU or in the wards. They are very nice, and they are happy to working together.
So in your experience, I see you're a scientist and you're keeping track of your patients' data. Do you see any potential therapies or medications that will work against the virus?
Okay. We have good experiences about pharmaceuticals nowadays. Hydroxychloroquine is widespread in Iran because, the malaria. Then hydroxychloroquine is producing in Iran from ancient time. The chloroquine was available in all of the pharmaceuticals. It's very widespread, and it is available in Iran. Okay, and it's a primary treatment. But for the next step, we're using the Caletra and ribavirin for the patients. Now, ribavirin is not working well in our patients, but at this moment, fortunately, we're using favipiravir. Favipiravir is a pharmaceutical that is not FDA approved, but it is a Japanese pharmaceutical. It's very nice. I asking the government to bring us the favipiravir, and the favipiravir will be available here for all of our patients in this hospital in the next week, and it's very nice. And I using other pharmaceuticals too, and we have good experience with the remdesivir recently, and this is another things that we're using nowadays. Another things that we are doing nowadays is tocilizumab. It was the diminishing of the IL-6 is very good, and with the help of WHO, we have these pharmaceuticals too. And when we getting the chest X-ray, before and after inserting this, everything will be changed in the chest X-ray so many times. We have a big trial for this. I published 2 days ago an article about our critical care pharmaceuticals. It was about the IVIG, and we using the IVIG in the early time of the ARDS. The ARDS is in the mild and moderate severe in Berlin criteria, and in this horrible disease, the mild and moderate and severe ARDS is very dangerous, more than the previous ARDS we met before. And we're using the IVIG in the mild to moderate times, not in the moderate to severe times. And we use interferon beta for many of our patients based on the protocol. And the other things we are using at this moment is amazing things. We are starting a trial with the stem cell for our at least 5 patients. And that was very good result for starting the stem cell. For these 5 patients was very magnificent, and the amount of intubation was reduced, and they are nowadays in a very good situations. It was very fantastic work we did. Clinical pharmacists are checking all of the protocols here, and we have 3 infectious clinicians here that are working every day and checking all of the people, the patients here, and checking the protocols. We did dexamethasone in the severe ARDS, then we have not any other pharmaceuticals for using that. Then this is another things we did, and it's not available in any protocols. When we are using, when you're missing our patients, and what is your idea about using more potent pharmaceuticals? Then we have a protocol for dexamethasone at this time, but it's not using in the ward. It's not using for the good people, good situation of the people, but we using for many of those based on ethics approval committee decision. This is another things we are using at this moment.
Oh, wow. Thank you so much. That sounds very comprehensive. And we're so excited to see some of these things pan out and really help patients around the world. So thank you for your work with research. And also, we appreciate your patients for allowing themselves to be in your care. As America gears up as a nation, do you have any advice for the American people about how they could best prepare themselves for the virus?
About the American peoples, it's better to remain to their home, as lots of people in Iran they have to remain in their home the first time. And about the physicians working in the ICU or in the hospitals, I don't know why you don't using the non-invasive ventilation. please. I think the patient safety is very important. I think.
Well, that's very good to know. Thank you.
Because we save lots of lives here with the non-invasive. You can checking my Instagram and see the live patients that they are on non-invasive ventilation. They didn't intubated, fortunately, and because I spoke with my friends in the US, and their problems are invasive mechanical ventilation and starting the ECMO, and they're starting the problems with the ECMO for those patients.
Dr. Hashemian, I want to thank you for that message, and I also, for our listeners who want to keep up with you and your experience, what is your Instagram handle so we can have everyone follow you?
Okay, critical_care_medicine. Critical care medicine.
Oh, that's a good one.
We'll put it on our profile for him.
Underline.
Underline.
Okay, thank you.
We're following you already. We're following you on Instagram. I just followed you right now.
Now, Instagram in Iran is very routine media. Maybe lots of people like the Instagram more than TV. And this is very widespread because in the early time of the corona, then all of the reporter, they don't like to come into the corona centers. I sending the peoples the events that are happening in the ICU and the hospital. And I report one of the patients that cured from the corona, and all of the people were very excited. And the TV getting my films, my video clips from my Instagram and showing in the TV report every day. And many times BBC report my Instagram for the patients that tolerate for example, the treatment or cure after many days in the hospitals. Then the Instagram is very popular in Iran.
I can only imagine that the BBC will be very interested in hearing your perspective on the Cardio Nerds podcast.
Oh, very good.
Definitely mention it.
Mm-hmm. Thank you.
Doctor,
I'd like to have more collaboration, and if you have any things for doing together, for example, the trials, or if you have any questionnaire to sending us for better management of our patient in Iran, please sending those for me, and please be in touch with me and my friends here. We have good friends here in all of the specialties. For example, we have surgeons, we have nephrologists, we have oncologists here that they don't know about the management of the COVID-19 in the previously time, and now they are working with us, and they are working for the treating the people nowadays here in my hospitals. And this is very fantastic that we are working together and we don't about the specialty at all here. And all of the physicians like to working against the COVID-19.
Amazing.
Yes, definitely. And really the thanks is all ours, Dr. Hashemian. Thank you so much for your time and for sharing so many amazing stories and your perspective, personal and clinical. It's very special for us to hear the Iranian perspective. It's something that we really have not heard so far. And happy belated Persian New Year.
Mm-hmm. Thank you. Thank you.
We look forward to collaborating in the future and seeing you in the U.S. when this is all over. We're sending our prayers and our love that we will all come out of this together.
Thank you. I like to sharing the traditionals with you guys, and we like to share our good times with you, American peoples and American physicians and American staffs, and appreciate you to be in touch with me and remaining awake at this time. Thank you for sharing your experience to me and sending my voice to all of the physicians around the globe. Thank you.
Well, that brings us to the end of our show, so it's time to make like an S2 and split. You can follow us on Twitter at CardioNerds. Don't forget to check out the amazing illustration that Kareen prepared for y'all at www.cardionerds.com, and please share what made your heart flutter this week. Send us a clip to cardionerds@gmail.com. If you enjoyed the show, be a nerd and spread the word. And now, a Flutter Moment.
Hey Cardio Nerds, my name's Dr. Edward Nejat. I'm a reproductive endocrinologist and fertility specialist at Generation X Fertility in Manhattan. What makes my heart flutter is, after doing an IVF cycle, the moment that the results come back for the first pregnancy test, my heart flutters like you wouldn't believe, because I know that result is going to change the course of someone's life forever.